I think আলামিন এখন বোধহয় শুরু করতে পারো, রেকর্ডিং ইন প্রোগ্রেস হচ্ছে।
Assalamu alaikum. So we are starting our second session of pre-operative evaluation of non-cardiac surgery, that is cardiac assessment. We have a distinguished panelist, and we two are moderator. We have Professor Chaudhary Ahsan Hafiz. He is a professor of cardiology, University of Nevada. We have Professor Abdul Wadud Chaudhary, who is the director of National Institute of Cardiovascular Disease and Hospital. And we have Professor Fazal Nasser. He is currently working as a professor at National Institute of Kidney Disease and Urology Hospital. We have Professor Abdul Momin, who works as a professor in the National Institute of Cardiovascular Disease, and Professor Shafiqul Islam, who is an anesthesiologist, currently works in Bangladesh Medical University as a professor. We have Dr. Sharmin Abbasi, who is a obstetrician and gynecologist, works in the United Medical College. We are two moderator. I am Dr. Alamin. I work as assistant professor in the Department of Cardiology, Bangladesh Medical University, and Dr. Mashrafi Ahmed, who is a clinical assistant professor in the Bay State Medical Center. So we have a presenter who is a very brilliant presenter, Dr. Shariful Halim, who will present 5 cases, and we will discuss 20 minutes every case. And I will ask the respected panelist different questions, and then audience can ask questions directly, or they can raise their hand, or they can put question in the chat box. So we will take we invite you your questions, and because this is a very interesting session, previously it created intense interest among our audience. So we conducted the second session. So I would now ask Dr. Shariful Halim to present his case, and Dr. Shariful Halim.
Um, uh, I'm sharing my screen. I'm sharing my screen. Can you see the screen, please?
Yeah, we see it, Dr. Halim.
Okay. So, respected panelists, moderators, and distinguished guests, Assalamu alaikum. It's a privilege to discuss a topic where teamwork matters more than anything else. This is cardiac evaluation before non-cardiac surgery. This is 2.0 because we have conducted a first session about a few months back. And today I will go like the previous session where I will have a few clinical cases where I will show the cases first, and then our distinguished panelists will discuss about the cases, and I'll show how we have dealt the cases and how MDT was achieved in all the cases. So first case is a 37-year-old male presented with STEMI anterior who received streptokinase. Before discharge, his echocardiogram showed anteroseptal and anterior wall hypokinesia from basal to mid segment and an akinetic apex. His ejection fraction was pretty low at 35%, and his functional status was NYHA 2. So after discharge, he developed hematuria. Now, then he visited local doctors who advised for ultrasound, and this is his ultrasonography of the KOB region, which shows a heterogeneous soft tissue mass in the lower pole of the right kidney. Now, this is the CECT, contrast enhanced CT scan of the abdomen, which again showing a exophytic mass in the right kidney, which is suggestive of renal cell carcinoma. Now, this new diagnosis created a set of conflict, which is we have a patient who was already thrombolized for STEMI, but he also has LV dysfunction with NYHA functional status 2. And now he is diagnosed as a case of large renal cell carcinoma in the right kidney, for which he needs surgery within 4 to 6 weeks. Now, this brings us to some big questions. The first question is, can we safely perform radical nephrectomy before stabilizing his coronary disease and his heart failure. Should CAG with PCI or CABG be done first instead of the radical nephrectomy? And then we go for the radical nephrectomy. So which one is first? Should we go for nephrectomy first, or should we go for CAG with revascularization first? That is our first dilemma. And then if we really do a PCI, does it create a antiplatelet trap where it creates a high bleeding risk for the nephrectomy? And when we are doing the PCI, what type of stent would be the best one in this case? So those are the questions that we had in our mind. And now I will pause and give the mic to the moderator.
Dr. Halim, can you make sure one thing that this patient had any chest pain?
Right now,
Yes.
right now, he does not have any chest pain. He does not have any chest pain right now. He's asymptomatic.
So he is asymptomatic right now.
Asymptomatic, but he has a shortness of breath whenever he has climbed more than 3 stairs. He has shortness
I
of breath.
think
He's
he has
NOH
NOIHA class 2 now.
NOH class 2 now, yes. But does not have any chest pain right now.
So I will request Professor Abdul Wazir Chaudhary, sir, if you have any comments right at this moment. Sir,
মিউট হয়ে আছেন।
স্যারকে একটু
Halim,
Sir,
স্যার জি স্যার শুনতে পাচ্ছি স্যার।
the problem you are presenting has two dimensions.
yes, sir.
This patient is living in Dhaka city, and where you can do whatever investigation you want.
Yes.
Let's say this patient presented to you in a Mofussil town. What will you do?
For so investigation for
Yeah.
assessment, sir.
Assessment. Because
Sir.
here we can go for a stress record, everything to assess, even without doing an ETT. I can at least assess his functional status to think about whether I should go nephrectomy first and then the intervention. Because the functional
Yes, sir,
status is very important, very important. He doesn't have any chest pain. Now, the
Yes, sir.
functional status is the most important thing that will decide how we can proceed.
Sir, Halim has told he has NOIHA class 2 right now, sir. And his functional status, he actually didn't mention. Halim, what would be his meds approximately so far you have assessed?
Meds is around 4 meds.
It should be more than 4 or
Yeah, because for
4, 5.
general anesthesia, 7 meds is the requirement that gives you a sort of comfort zone.
sir.
Yeah, so he has like moderately reduced meds, around 4 to 5.
And the thing is that we often forget that NOIHA class is of subjective.
Yes, sir.
Yes, sir.
That's very important. I don't know about his previous status. Now you are saying NOIHA 2, but if সে যদি সম্ভব গতিতে হাঁটাচলা করে তার তো NOIHA 2 থাকবেই। আর
Sir.
মসজিদে যাওয়ার জন্য যদি একটু তাড়াহুড়া করতে গিয়ে যদি হয়রান হয়ে যায় তাহলে অ্যাকচুয়ালি তার স্ট্যাটাস বোঝা যাবে। কাজে NOIHA স্ট্যাটাসটা যাচাই করার জন্য কোশ্চেন গুলো কিন্তু অ্যাপ্রোপ্রিয়েট হতে হবে।
Yes, sir.
Yes. Sir, would you recommend stress test right at this moment, or you will take history and you will proceed to surgery, or you will proceed to revascularization, sir?
What about his age?
He's 37 years old, sir.
Yeah, he's very young.
Yes, sir.
So I would prefer an exercise test.
Exercises, right, sir. So, Dr. Mashrafi, what would you practice in USA in this case?
Good question. I need to clarify a few things first from Shariful Halim.
Sir.
So Sharif, patient পেয়েছে streptokinase, বোঝা যাচ্ছে যে
Yes,
anterior
Shariful Halim.
টেমি এসেছিল।
Yes, yes.
আমাদের কোনো
Enterostomy and
coronary
streptokinase
angiogram
পেয়েছে।
করা নাই, right?
না, কোনো অ্যাঞ্জিওগ্রাম এখনো করা হয় নাই, কারণ এটা
এখনো করা
সে
হয়নি।
এসছে হলো ঢাকার বাইরে থেকেই একটা হসপিটাল থেকে সে অ্যাঞ্জিওগ্রাম করে স্ট্রেপটোকাইনেস পেয়েছিল, পরবর্তী সময়ে হলো যে নেফ্রোলজিস্টের কাছে রেফার্ড হয়েছে বিকজ অফ দ্য রেনাল ম্যাস। দেন হি
মানে
কেম
আমরা
টু ঢাকা অ্যান্ড
তুমি যদি টাইম পিরিয়ডের কথা বলো যে কতদিন আগে আসলে এমআইটা হয়েছিল?
এমআইটা হয়েছিল 1 সপ্তাহ আগে, মানে এক
আচ্ছা।
সপ্তাহ আগে সে এমআই হওয়ার পরে 1 সপ্তাহ পরে তার হেমাচুরিয়া হয়, তখন সে লোকালি ডক্টর দেখায়, ওখানে আলট্রাসাউন্ডে ধরা পড়ে যে একটা রেনাল ম্যাস। তারপরে সে ঢাকা আসে, ঢাকায় এসে একজন সার্জনকে দেখায়। সার্জন পরে হলো যে আমাদের কার্ডিওলজিস্টের অপিনিয়ন নিতে চায় বিকজ দে ওয়ান্ট টু ডু সাম অ্যাডভান্স সার্জারি করতে চায়, নাও কার্ডিয়াক ক্লিয়ারেন্স দরকার, তখন আসলে আমাদের হাতে আসে পেশেন্টটা। তার আগ পর্যন্ত আমাদের কাছে ছিল না।
সো এই ধরনের কেসে it's a tricky situation, right? Like patient
Yes.
just had an MI, anterior MI, hereditary involvement. We do not know two things here. One is when the patient had MI and got streptokinase outside Dhaka, whether it was really reperfused or not, or he really had the LAD territory completely infarcted or not, right? So
Yes.
because if this LAD territory is infarcted and already dead, your intervention, your questions are there. The intervention is really gonna help or not, right? So
Yes.
Yes.
according to the OAT trial, it really does not matter whether you intervene or not. So সেটা হচ্ছে একটা বড় কোশ্চেন। এবং সেকেন্ড কোশ্চেন হচ্ছে যে সার্জারিতে তুমি খুব বেশি ডিলে করতে পারবে না এখানে, রাইট? কারণ
Yeah, 4 to 6 weeks. Yeah.
seems
Yeah.
like this is as a young guy, you do not take a chance to get it metastasized or something bad happen, right?
Yes. Surgeon
So
told us
এখানে
that the TNM status would be same for 60 days. So maximum 60 days he could wait, but not more than that.
right, আমাদের এখানে যে ফজল নাসির স্যার আছেন,
He was actually the surgeon who actually dealt with the case, sir.
তো ফজল নাসির স্যারের কাছে আমার প্রশ্ন হচ্ছে যে এই ধরনের সিচুয়েশনে we suspect that this is a mass and this is probably malignant. Do we need to even consider biopsy or not? Number one. Number two, if we do not need to consider biopsy, by appearance it is already malignant, is there any time period he should get it done, or is there any option to wait 3 months or not?
Well, thank you for your nice questions. So nowadays, for the advancement of the imaging, especially these CT scan, the triphasic CT scan, the accuracy is so good. In 95% cases, we can accurately say whether this is a malignant or the benign case. The case that has been discussed here is a typical case for the RCC. So there was no need for the biopsy. And at present, we do not do biopsy. It was a very, very low indication for biopsy. And as you are aware that the RCCs are basically, the malignant potential is very low. So we can wait, especially in case of old ages. After the age of 60, there is options for the watchful waiting or the active surveillance like that of the prostate cancer. And in some cases, whether the patient is not capable for the general anesthesia, we do not do anything in case of RCC. But particularly in this case, a man of 37 years, and in younger ages, sometimes the malignancy could be more aggressive. But in the CT scan, what we saw that in this case, we can get time. At least we can wait for 2 months' time. That is the 60 days or the 65 days could be fair enough to wait and to deal with the cardiac problem and then go for the surgeries. Thank you.
So thank you, sir, for your very important input. Dr. Halim, one thing is very interesting that Professor Abdul Wahid Chaudhary sir has mentioned. Did you think about any stress test?
Yes, we thought about stress tests, but because of the NYHA2 and the recent MI, and the patient did not actually, we considered the patient, but the patient was not like very comfortable with the stress test. We offered him with the modified Bruce protocol, but probably we failed to convince him. And
So
he actually,
there can be two schools of thought right now we are standing. One is that we can go for stress testing if METS is more than 4 and there is no significant ischemia, we straightly could proceed to surgery without revascularization. That is one option. Another option is that if stress test could recognize very high burden of ischemia, then we could have considered revascularization before surgery. So right now we're standing. Let's see what did you do.
so then we held an MDT meeting with the cardiologist, the surgeon, and anesthesiologist, and they wanted our clearance for going for surgery because they were reluctant with this type of recent MI and this low ejection fraction with NYHA 2. So then we actually did the coronary angiogram.
Shariful Halim, I will interfere you. One thing is that the low ejection fraction, the coronary heart disease, or even the MI, that actually is important in one way. Another is important that how far patient is ischemic right now, how far the patient is symptomatic. Symptom is quite important. If patient have NOH 3-4, you can defer
NYHA
surgery.
NYHA 2.
Patient is
NYHA 2?
NOH 2, you can
NYHA 2.
proceed to surgery. So it's not by instinct. We can avoid surgery because of low ejection fraction. I
Yes,
think
yes. If it's
symptom is more important.
NYHA 4, then we can stop the surgery. But right now,
Okay, you can
that was-
proceed now.
yeah,
Yes. Let's
our
see what did
decision
you do.
was to go for the CAG and to see what was the coronary anatomy. And this is the coronary angiogram, which shows significant lesion in the proximal LAD, and then we can see a significant lesion in the ramus, and also a lesion in the RCA, proximal RCA. So this is the angiography report. We have 90% stenosis in LAD and ramus disease, and also disease in the RCA. Now the question was, first, would you go for revascularization now, or would you go for surgery now? Or if we go for revascularization, what would be the best method of revascularization? Is it PCI or is it CABG? What does the Syntax score say? What does the Syntax 2 score say? What is the
So,
mortality
Dr.
risk?
Halim, okay, Dr. Halim, Dr. Mashrafi. So, right at this moment, you want to PCI, or you can keep this right at this moment and go for surgery, nephrectomy.
Sorry, question টা আবার বলো।
Question হচ্ছে যে এই অবস্থায় যে লেশন আমরা দেখলাম, the lesion we have seen, should we proceed to revascularization, or seeing this lesion we can go, yes, there may be lesion, but we can proceed to surgery, nephrectomy, because this is time sensitive malignancy we suspect.
Right. So once again, coronary artery disease can be, this is a 37-year-old guy, right? তো coronary
Yes.
artery disease আছে, এটা 67 ও হতে পারতো, তারও coronary artery disease থাকতে পারে। But coronary artery disease does not mean that we have to prohibit the surgery. True, any acute coronary syndrome পরপরই যে কোনো ধরনের কার্ডিয়াক ইসকেমিক ইভেন্টস সার্জারির সাথে বেশি হয়, right? So after 6 months of any acute coronary syndrome, the cardiac morbidity is higher. But in this person, we don't have probably time for waiting for 6 months, has to get done. The question হচ্ছে যে আমরা কি আগে রিভাসকুলারাইজেশন করব বা আগে সার্জারিতে যাব? So আমরা লেশন গুলো দেখতে পাচ্ছি, but this lesion is already had a plaque rupture and now is healing, right?
Yes.
So the question is, পেশেন্টের কোনো সিমটম আছে কিনা? যদি পেশেন্টের সিমটম না থাকে, শরীফ তুমি একটু আরেকবার গো ব্যাক করবে একটু ইয়েতে অ্যানজিওগ্রামটা।
Yes, sir.
আমি শুধু দেখতে চাই আসলে কতটুকু খারাপ, রাইট? সো তোমার এলএডি ডিফিউজলি ডিজিজ, রাইট? আটকে যাচ্ছে আসলে। You have some proximal RCA disease.
Yes. And also some disease in the ramus.
You have some disease in the ramus. কিন্তু আটকে যাচ্ছে, আমি ঠিক আসলে ধরতে পারছি না, কিন্তু রেমাসটা মনে হচ্ছে খুবই ছোট।
Ramusটা, yeah, it's a small vessel.
right?
Yes.
So Raymonster small vessel, there is some disease in the RCA, proximal RCA,
Proximal RC, yes, sir.
and some disease in the proximal LAD.
Yes.
But how bad are they? That's the question. Are they creating symptom or not? So yes, patient had an acute coronary disease syndrome a few weeks back, but these unstable plaques are already healed.
Yes. Already
Right?
healing. 7 days gone, yeah.
Right, already healing. So
And he's taking DAPT with ecosprin and clopidogrel, and
right.
also receiving statin. Yeah.
And if he does not have symptom, if he can really achieve some degree of activity, the safe margin as we were talking about, maybe I'll just proceed with the surgery first, so that
So
we
that's
do
a
not
very
have
good.
to,
Okay, sir.
we
So
do not have
here
to
I have
interrupt the antiplatelet.
yes, here I have
So
a question regarding the surgery after MI, because
Dr. Shariful Halim, I just want to mention one thing for the audience is that coronary artery disease, even if it is triple vessel disease, that is not prohibitive of surgery.
okay, sir,
The
here I
issue is
have
that
to,
how far ischemia it is producing.
okay, but here the one of the big issue that we are forgetting that this is a post MI patient and he's a recent MI patient, and one of the thing with the recent MI that post MI there is a high risk of rethrombosis and recurrent MI, especially if the surgery is done within 1 month, even if the stent is not given.
That is
There
a very
is
good point. That is a
there
very
is a
good point.
risk of reinfarction. If we do the surgery right now, the patient is already in a prothrombotic state, and surgery will create more prothrombotic state, and there maybe we might have a recurrence of this MI again. So that was a big
So
concern for
Shariful Halim,
us.
so we have two issues. It is a post-MI, post-acute coronary
Yes.
syndrome patient.
Yes, sir.
We usually do not do elective surgery within 3 months of MI. That one
Yes.
issue is that. Another issue is that he is residual coronary artery disease.
Yes.
So Professor Wadud sir is here. Sir, what would be your suggestion right at this moment?
Do you know what I would have done? He's a
Sir.
37-year-old.
Sir.
And the neurosurgeon is saying he can wait up to 2 months.
Sir.
I would wait at least 4 to 6 weeks. Then I would do the stress test and go for surgery.
So I think this is a wonderful approach, because fixing the coronary lesion always does not reduce death or events after surgery. So that could be at least 6 weeks deferral of surgery, then a stress test, and if we can achieve more than 4 months, we can proceed to surgery without revascularization. This is one option. Let's see what Shariful Halim did.
So Sharif, let
Yes,
me
sir.
ask you a question.
Yes, sir.
When we talk about pre-surgical cardiac risk assessment, we know that we always focus on ischemia or MI,
Yes, sir.
right?
Yes.
But ischemia or MI is not the biggest incidence in the perioperative period, right? What is the biggest incidence in the perioperative period?
There
for
can be
these group of
failure.
patients?
It can precipitate failure as well, because already LV function is
So
reduced.
the risk of heart failure exacerbation is the biggest for not only this group of patients, for any group of patients.
Yes, sir.
Perioperative cardiac risk assessment, we usually try to sort of assess a couple of different things. What is the risk of heart failure exacerbation? What is the risk of some sort of arrhythmia, atrial fibrillation? And what is the risk of MI or ischemia? And if you look into the data set, you will see that the heart failure incidence in the perioperative period is the highest, 8 to 10%.
Yes, sir.
Then comes the arrhythmia or atrial fibrillation, close to like 5 to 6%. AMI is usually the lowest. It's usually close to 2% or less. But we are always the most concerned because that is the most life-threatening situation probably. But if you look into the incidence, the MI is usually the lowest incidence reported in the perioperative period than the other two.
Yes.
Thank you, Dr. Mashabi. This is brilliant information. Okay, let's see, Shariful Halim, what did you do?
আলামিন, আমি একটা কথা একটু বলতে চাই নাসের।
Sir, sure, sir.
হ্যাঁ, আচ্ছা, আমি একটু বলতে চাই এখানে একটা খুব টেক হোম মেসেজ খুব ইম্পর্টেন্ট, যারা আজকে আমাদের জুনিয়র অডিয়েন্স আছেন। তুমি যদি মাশরাফি এবং আমাদের প্রফেসর ওয়াজিদ স্যারের কথা শুনো, সবচেয়ে ইম্পর্টেন্ট প্রেডিক্টর হচ্ছে এক্সারসাইজ ক্যাপাসিটি। অ্যাজ লং অ্যাজ দ্য পেশেন্ট হ্যাজ গুড এক্সারসাইজ টলারেন্স, দ্য পেশেন্ট উইল ডু ওয়েল রিগার্ডলেস। সেটা সার্জারির বেলায় হোক বা যে কোনো তার লং টার্ম আউটকামের বেলা হোক, দ্যাট ইজ মোস্ট ইম্পর্টেন্ট প্রেডিক্টর। এই মেসেজটা দেওয়া খুব ইম্পর্টেন্ট।
Yes, sir. Exactly. So, all the textbook, all the guideline emphasized on how the patient is doing, what is the patient's symptoms, what is the best he can achieve functional status. This has been emphasized several times.
And important that pre-surgical revascularization never in any studies showed reduction in mortality or incidence.
Yes, sir. Okay, Dr. Shariful Halim, you can proceed.
Okay, so I think the board is against revascularization, but we took a different turn. In our case, we assessed the Syntax score, which was 12. Syntax 2, CABG prognostically favored, but we thought about CABG and nephrectomy in a single setting, but that gave us a very high risk of mortality. So we discussed about those in the heart team, and we actually did the PCI. We actually did the PCI to RCA with a Resolute Onyx for RCA. We also did the PCI to LAD with the Ultimaster 10C, which have a low thrombotic risk. And then after 6 weeks following the PCI, our surgeon did the laparoscopic radical nephrectomy with management of DAPT. Actually, the patient was getting ticagrelor after the PCA. We stopped the ticagrelor 5 days before, and we started the infusion iptifibatide, and we stopped it before 6 hours of surgery. And then we reloaded the patient with the clopidogrel. And this is the laparoscopic radical nephrectomy procedure. You can see the bleeding was minimal during the procedure, and a successful surgery was done. So that was my case.
So, Professor Fazal Nasser, sir, you are here. We can hear from you. Actually, how did you, how much bleeding you observed, and what difficulty you faced during this surgery?
Thank you again, Alamin, for your nice questions. So actually, it was as usual. I didn't find anything more difficult than what I usually do with the normal patient. So it was like normal, and the plane was very good, and it was very shorter period. I think 26 minutes times I took only to get out the total kidneys. So basically, I didn't face any problem with the bleeding.
Sir, I have some questions to you regarding this. There are laparoscopic way you have done this surgery. So is there a difference between laparoscopic procedure and open methods that can confer cardiovascular benefit?
Yeah, laparoscopic procedure has got two disadvantages or extra stress to the patients. One is the mechanical and one is the biochemical. As you are aware, we use the carbon dioxide, and there is a raised intra-abdominal pressure. So venous return is reduced, and often we keep the favorable positions like the lateral positions, sometimes head down positions, sometimes leg down positions. So there is venous return and the diaphragm is always get compressed. So it causes extra stress to the heart, as well as the carbon dioxide itself causes some difficulties with the cardiovascular system. The heart get depressed also at that time due to the carbon dioxide. You know, the coefficient of the carbon dioxide solubility is more than oxygen and other gases. So it's radially diffuses through the peritoneum to the blood, and there is the hypercapnia at that time. So there is cardiac depression also. So in this particular case where there is cardiac problem, we are very cautious. So what we do, we try to keep the pressure as low as possible. Sometimes we take the mechanical some devices to lift up the abdomen so that we need less and less carbon dioxide pressures. And the imaging system is important in case of laparoscopy. The good imaging system is required. The good energy sources, that is the vascular sealer, is also required. And moreover, the experience of the surgeons. In these particular cases, you have to be very experienced to deal and overcome with every situation you face during this procedure. Thank you.
Professor Fazal Nasser, congratulations for this brilliant job, and as you always do. Can you give us some idea that what sorts of cardiovascular problem you face during surgery most of the time, and why surgeons are so concerned about cardiovascular problem during surgery?
Well, in our initial days, when the laparoscopy was at the inceptions in Bangladesh, see, the rapid pneumoperitoneum with the carbon dioxide is very dangerous because sudden rise of the intra-abdominal pressure, sudden fall of the venous return, and sudden thrush of the diaphragm causes vasovagal attack, and sometimes there is cardiac arrest also. So nowadays, say for the last 12 or 13 years, we're still practicing slow pneumoperitoneum. So this is one of the reasons, is a very concern. And other things that the kidneys or the total urology is very closely proximate with the branches of the abdominal aorta. So there are chances of bleeding. And sometimes the renal artery may be injured, sometimes vena cava may be injured. So this is a sudden gush of bleeding, and there is a fall, and there may be cardiac arrest also. So what I have said, during my fellowship in abroad, my mentors always said that do not change your step ladder, or do not climb to the upstairs without climbing through the step ladder. So there is a formula, or there is a guideline done by the European Association of Urology. They have divided the laparoscopic urology surgeries into 6 phases of the difficulty grades. That is the 1, 2, 3, 4, 5, 6. And the young surgeons should follow this. They shouldn't do the nephrectomies or cystectomy or prostatectomy in the first instance. So they have to learn the plane. They have to know the anatomy and the variation of the anatomy.
Sir, another thing I want to that during surgery there is fluid shift, there is inflammation, there is fluid overload. All these things puts cardiac stress.
Yeah,
So
definitely.
So all these things to complicates these surgery procedures, and there may be cardiac arrest or heart failure or MI during this procedure. Is it like that?
Yeah, it could be. It could be. So preoperative assessment is very essential. And always the echocardiograph, if it is required, the stress test, even CAG may be required before proceeding for many major surgeries to minimize the complication. There may be complication. Even then, after full assessment, there may be chances of complication.
Complications, yes, sir.
Yeah. Unwanted complication there may be.
Thank you, sir.
নাসির ভাইকে একটু কোশ্চেন করি, কারণ একটা চ্যাট বক্সে কয়েকটা কোশ্চেন আসছে। নাসির ভাই আছেন না?
সরি, আমি একটু স্পটি আর কি আমার ইয়েটা বলো, অসুবিধা নেই।
আচ্ছা নাসির ভাই, চ্যাট বক্সের কোশ্চেন হচ্ছে, if functional capacity less or stress test is positive, then what? Can DC be a choice, and FFR could be a guidance or not?
If the stress test is abnormal, then that becomes definitely, I would proceed with angiogram. I mean, সেক্ষেত্রে আমি মেইন আমার কনসার্নটা হবে যে লেফট মেইন ডিজিজ বা ট্রিপল ভেসেল ডিজিজ বা অস্টিয়াল এলএডি ডিজিজ আছে কিনা। যদি সেরকম থাকে, যদি আমাকে সেটা ফিক্স করতে হয়, probably if the patient has to go to surgery soon, DCB could be an option with short-term gap, and then the patient can go for surgery. তোমার প্র্যাকটিস কি মাশরাফি?
আমার প্র্যাকটিসে হ্যাঁ, যদি পেশেন্টের অ্যাবনর্মাল স্ট্রেস টেস্ট বা সিমটম থাকে তাহলে তখন অ্যানজিওগ্রাম করব। DCB, I'm not really sure. DCB is probably so far not approved for this in large vessels post-MI here. FFR, I would not really go decide anything on FFR. FFR is not an indication here to decide whether we are going to go for or not.
Our
একটা
country,
ব্যাপারে আমি এখানে এখানে একটু একটু তোমার সাথে অ্যাড করি মাশরাফি, তোমাদের প্র্যাকটিসটা significantly changed. I kind of agree with you. The practice significantly changed with the new generation of stents. আগে যেমন আমরা খুব কনসার্ন ছিলাম, এখন আমরা শর্ট ড্যাপকে মানে even if it's a drug eluting stent, after even a month of DAPT, they can go for surgery. So the patient can go wait for 4 weeks. I would just go and stent it with a new generation drug eluting stent, and the patient can go for surgery. But তুমি যদি আমাকে বলো যে 2 সপ্তাহের মধ্যে যেতে হবে, সেই ক্ষেত্রে হয়তো বা DCBটা could be an option, but I still would prefer the drug eluting stent. I agree with you in that regard.
Right. In fact, এই যে তোমার শরীফের একটা কোশ্চেন ছিল যে what type of stent, এখন আসলে আর বেয়ার মেটাল স্টেন্টের না খুব একটা ভ্যালু বোধহয় নাই, কারণ এখন যে শর্ট ড্যাপ্টের যতগুলো ট্রায়াল চলে এসেছে, everything is on drug eluting stent, and it is okay or safe to discontinue your dual antiplatelet therapy after a month or so if you need it. So bare metal stent আসলে এখন বিশেষ করে আমাদের হাসপাতালে এখন আর bare metal স্টেন্টই নাই. We don't get bare metal stent anymore.
Exactly. So, I don't even remember when I used the bare metal stent.
Either you can go for the new generation stents. They require only 1 month DAPT is enough for them.
Yes, sir.
Right.
We,
Yes, sir.
we use our
So-
Ultimaster 10C, sir, which was proven in the Master DBT trial.
So I can wrap up that. So for the discussion of the case, the number one issue is symptom is important. Number two is during acute coronary syndrome, we and newer drug eluting stents we can do surgery even after 1 month, and always meds is important. So these are all the key information of this case, and we can proceed. We have still 4 cases, and we can
Okay,
proceed to
sir.
the next
I'm
cases.
proceeding to the next case. So this is a 58-year-old hypertensive man who is planned for laparoscopic cholecystectomy for symptomatic cholecystitis. And his blood pressure is 148/90. He has been taking 3 drugs, amlodipine 10 milligram, losartan 50 milligram, and thiazide 12.5 milligram. Now, what should be our decision regarding this surgery? Should we proceed? Should we pause for the BP control, or should we cancel the surgery right now?
Sir, Professor Fazal Nasser sir is here. Sir, from surgeon's perspective, what do you practice in this sorts of case? Professor Fazal Nasser sir. Okay, Shariful, you can proceed. I think
Okay,
is
sir.
muted.
Okay, sir. So our thinking points were it was an intermediate surgical risk procedure. It was an elective surgery. The patient had good functional capacity, more than 4 meds. And we assessed for any unstable cardiac condition. He didn't have any SCS, heart failure, arrhythmias, valve issues. And we measured the BP again in a resting status. We screened for any hypertension-mediated organ damage, including headaches, neurodeficit, chest pain, pulmonary edema, or AKI. And then we decided to proceed with the medication adjustment. So we continued the amlodipine. We discussed about the withholding of the ARB because it will blunt the response of the RAS system during surgery. And also we stopped the diuretics. So our plan was accordingly performed by the patient. Patient took amlodipine on the day of surgery, but he didn't take losartan or thiazide. And then we planned to restart once the patient's surgery was done and the patient is stable. So this is what happened on the surgery day. On arrival in the OT, we measured the BP again. It was 150/90. We proceeded to operation. Paraoperatively, the anesthesiologist was informed about the hypertension. He did a smooth induction, the pneumoperitoneum in a low pressure and slow pneumoperitoneum. He measured the BP in frequent intervals, and the anesthesiologist avoided any pain or anxiety surges. The main concern was to avoid any hypotension, and our hemodynamic target was MAP of more than 60 and systolic blood pressure more than 90. And the patient was stable postoperatively. We restarted the antihypertensive from the next morning, and we planned to discharge right then. And we plan to follow him up with the adherence and escalate the therapy if the BP remains high. So this was our second case.
Professor Shafiqul Islam, sir, are you here? Are you with us? The anesthesiologist. So I think he could not connect.
I'm curious to know also from Sharmin Abbasi about when you in gynecology obstetric world, you guys have this sort of scenarios where hypertensive urgencies happen in maternity, pre-maternity surgical scenarios. How much you guys are concerned, or what's the culture for cardiac assessment prior to OB or GYN surgeries?
Thank you, Mashrafi Bhai. Usually in gynecological point of view, we are the gynecologists, but for the cardiac evaluation, we also always try to follow the MDT approaches. Actually, with the cardiologist, we discuss, and after that, we will take the decision. But for the gynecological surgery point of view, it is extremely important from our thinking, that is surgery, anesthesia, blood loss, fluid shift, pain, and also the stress all together actually put the strain on the heart and also to the circulation. So we actually, from the gynecological point of view, try to assess the fitness. So in our country, our Obstetrical and Gynecological Society of Bangladesh have a guideline. According to the guideline, we firstly assess the patient from the anesthetics point of view by our general examination, and also do the regular investigations. And in our chamber or in our outdoor setup, we actually want to see the blood pressure of the patient, the heart rate, the pulse, and try to assess the patient. And sometimes some patient come with a normal blood pressure, they treat in one way, but sometimes the patient come with a hypertension or ischemic heart disease or arrhythmia. So at that point of view, we need to take the opinion from the cardiologist.
Yeah, Dr. Sharmin Abbasi, yes, you need to take opinion from cardiologist. But if blood pressure is 150 by 100, so
Yes.
you have a hysterectomy, would you proceed to the surgery, or you will control the blood pressure and then proceed to the surgery?
We try to reduce the blood pressure. In our obstetric and gynecology guideline, we try to keep the blood pressure before the surgery is less than 140 by 90. So,
Okay, Dr. Nasir Khan, sir, can you hear us? Dr. Nasir Khan,
but
sir.
sometimes we get some sort of patient who come to the preoperative room and just sudden rise of the blood pressure, and we can reduce the blood pressure in the same sitting after 1 or half an hour or 1 hour. At that time, we will proceed with our surgery. But before
what
the
is
surgery,
your drug of choice in just before surgery? You saw that the patient's blood pressure is like,
actually we take
many
the
times it's just because of anxiety, right? Like it could be just because of anxiety, patient's blood pressure is 160, 170. What's your drug of choice right at that time?
Actually, we take the help from the anesthesia. This is the main
Yeah,
thing.
anesthesia.
Yes, we personally don't prescribe any drug. We take the help from the anesthesia.
Okay, suppose if the blood pressure is high, then what problem this patient may have during surgery?
Because mainly now in Bangladesh, the laparoscopic surgery are mainly ongoing more. In hysterectomy, our gynecologists are doing more the laparoscopic hysterectomy than the open. So when the blood pressure is more, there are chances of the more bleeding in the perioperative field. And at the same time, in laparoscopic surgery, which is Fazlun Nasir sir told us that there are some systemic changes also. We need to keep it in mind. There's a chances of the arrhythmia, and also there is a problem in the venous return. So as a whole, if the blood pressure is raised, and we will proceed with any elective surgery, which can have the options to switch over to another day, I think it should be avoided. And our guideline of our country is also that to stable the patient, to make the blood pressure in optimum level, and then proceed for the elective surgery.
Dr. Mashrafi, what's written in the guideline that if blood pressure is not more than 180 and 110, surgery should not be deferred. What do you practice in USA?
Blood pressure, if you look into the new guideline, right, the pre-surgical cardiac risk assessment, and আমি বলছি আসলে যেটা হচ্ছে এখানে যারা ইয়াং জুনিয়র ডাক্তার আছেন তাদের জন্য pre-surgical cardiac risk assessment for non-cardiac surgery যে নতুন গাইডলাইন এসেছে আমেরিকান কলেজ অফ কার্ডিওলজির, সেখানে আসলে মেইনলি কার্ডিয়াক কন্ডিশন গুলো নিয়ে কথা বলেছে। ব্লাড প্রেশারের জন্য কোনো স্পেসিফিক মেডিকেশনের কোনো আসলে ওরকম সাজেশন ওভাবে সরাসরি গাইডলাইনে দেওয়া, কিন্তু ব্লাড প্রেশার যদি 180 হয় তাহলে যে কোনো প্রিসার্জিক্যাল যে কোনো ইলেকটিভ সার্জারির ক্ষেত্রে we try to lower the blood pressure by some quick acting medications. So most of the time what happens, patient come empty stomach, right? কারণ anesthesia পাবে। empty stomach যখন বলা হয় তখন পেশেন্টের একটা বড় অংশই আসে হচ্ছে তাদের রেগুলার যে ব্লাড প্রেশার মেডিকেশন গুলো তারা খেত, সেই মেডিকেশনটা হয় তারা সেদিন সকালে খায়নি, সাথে আছে অ্যাংজাইটির প্রবলেম। সো এই দুটোর কারণে অনেক সময় দেখা যায় যে ব্লাড প্রেশার অনেক বেশি। If it is 180, yes, we try to reduce the blood pressure in the preoperative, setting. Depends on what exactly patient was getting in the past and whether there is any particular contraindication to any particular medication. Most commonly used drugs are usually the labetalol or hydralazine in that sort of scenario. These two are the most commonly used drug, even during the surgery or during the procedure. These are the most commonly used drug to control the blood pressure when it is more than 180. And at the same time, definitely anesthetic agents come with the relaxation and all this sort of thing. So that helps to reduce the blood pressure as well. So if we see that the patient, particularly our procedures where patients are in moderate sedation rather than full general anesthesia, we see whether the patient is uncomfortable or not. If the patient is uncomfortable, rather than just targeting with antihypertensive medication, we try to see whether any sedatives or pain medication also reduce their anxiety, reduce their pain threshold, and that can lower the blood pressure by itself.
Okay, sir. So, Professor Wadisudi, sir, for your comments about this case, and we will move on to the next case.
One of my observations regarding this preoperative control of hypertension is that in our country, people are more sympathetic driven. They have rapid rise of blood pressure because of anxiety. And all of the surgeons have experienced where the patient was normotensive totally, not getting any antihypertensive, but on the OT, the pressure is going up 240 or more. The diastolic pressure going up 120, 140, something like they have to abandon OT many times. Just only because of anxiety. That level of anxiety, that level of blood pressure driven, unless you have the experience, you won't believe it. Now, to my whenever we are getting patient like that, one of my key rule is that I tend to continue a drug which is very long acting, but not at a higher dose, like amlodipine. If it is a half-life of around 2.5 half days. So even when the patient has taken the drug the night before, and in the morning, if you do not continue any other antihypertensive, still the effect of amlodipine will be there to protect to the baseline level. Now, the second thing is, please have a chat with the patient. Try to allay the anxiety that the patient has. And that really helps. And third thing is, I always check whenever the patient is getting a diuretic beforehand, I always check the electrolyte because many a time they have low potassium. And that creates the chance of arrhythmia during anesthesia. That should be taken care of. You keep your potassium high up, and a bit around 4.5, you have lesser chance of ventricular arrhythmias. And that gives a sort of protection, particularly from the anesthetic point of view. Postoperatively and paraoperatively, in this patient, if they have LVH particularly and diastolic dysfunction, if you give too much fluid, they will develop pulmonary edema. So I tell my surgeon, if the patient has the echo shows LVH or concentric hypertrophy or concentric remodeling or diastolic dysfunction, please ensure that the patient is not getting too much fluid. And that will prevent the lung flooding out from acute pulmonary edema. And afterwards, if the patient cannot take anything orally, IV beta blockers like labetalol is a blessing. So that can be used very wisely. And the ease with labetalol use is that it does not reduce your heart rate too much, but to some extent. So if the patient has high heart rate, it does reduce that, but it does not reduce it too much so that you get worried that I am using high-dose labetalol and the patient is getting bradycardia. That's very helpful.
Thank you, sir.
আমি এটা আলামিন ভাই ওয়াদুদ স্যারের কাছে একটা রিসেন্ট পেশেন্ট নিয়ে একটু ওপিনিয়ন নিতে চাই, যদি আপনি পারমিশন দেন। এক মিনিট লাগবে আমার। সেটা হচ্ছে একটা ভেরি ভ্যালুয়েবল প্রেগন্যান্সি, আইভিএফ প্রেগন্যান্সি। পেশেন্ট ওয়াজ অল থ্রু তার 40 উইকস পর্যন্তই নর্মোটেনসিভ ছিল। দেন আমরা সিজারিয়ান সেকশন করলাম। ইমিডিয়েট পোস্ট অপারেটিভে পেশেন্টের ব্লাড প্রেশার হলো 220 সিস্টোলিক অ্যান্ড ডায়াস্টোলিক 150, এবং তার সবকিছু নর্মাল। কার্ডিয়াক ইভালুয়েশনও করা হয়েছিল, সবকিছু নর্মাল। এবং এই ব্লাড প্রেশারটা আমরা যখন কার্ডিওলজিস্টকে কল দিলাম, তারা প্রথমে ডায়োটিক্স দিলেন, তারপর এটাকে কমানো যাচ্ছিল না, তারপরে অ্যামলোডিপিন অ্যান্ড বিটা ব্লকার তারা অ্যাড করলেন। তারপরেও 2 দিন ধরে আমরা ব্লাড প্রেশার সিস্টোলিক 180, ডায়াস্টোলিক আসলে 110 এর নিচে নামাতে পারছিলাম না। এটা আসলে কি কারণে হলো? কারণ অল দ্য থ্রু তার সবকিছু নরমাল, সে সবসময় নর্মোটেনসিভ।
This is pregnancy-induced hypertension. This is preeclampsia. This is preeclampsia.
Proteinuria নেই স্যার, আর সবকিছু তো নরমাল।
That will go into eclampsia. If you have progressive preeclampsia, you will get that. But this is pregnancy-induced hypertension, and the drug of choice is, of course, is labetalol. And
right.
You can use very high dose. And I prefer to use infusion rather than giving a few hours gap. And
sir, পুরো প্রেগন্যান্সিতে তো ব্লাড প্রেশার নরমাল স্যার, পোস্ট অপারেটিভ ইমিডিয়েটলি
pregnancy-induced hypertension does not need to have the hypertension beforehand.
Okay, sir. জি।
Preeclampsia can occur after even delivery. Just remember that.
Yes, sir.
Yes. So the key information from this case is that in surgeons, anesthesiologists mainly what they are afraid of, hypotension. Actually, hypotension is more common than hypertension during surgery. But before surgery, hypertension is common, particularly during stress, anxiety, and like that. So Sariful Halim is very nicely gave a slide that mean arterial pressure should be more than 60 or 65. And should be avoid hypotension. There is a question in the chat box that should we use ACE inhibitor during perioperative period? If it is for hypertension, if we can avoid ACE inhibitor, that is class 2B indication from ACC AHA 2024 indications.
Yes, sir.
But if it is for heart failure, that is fantastic. As a part of Fantastic Four, it should be continued during the perioperative period of surgery. So, Sariful Halim, you can move to your next case. I think you can move to the pacemaker case.
Okay. So this is my third case. This is a patient, a 72-year-old male, diagnosed with colorectal carcinoma. But he had a dual chamber pacemaker implanted 4 years back due to complete heart block. And the device is located in the left pectoral region. There was a follow-up echo 8 months back, which showed a normal EF and mild LVH. He's hypertensive, diabetic, and has CKD stage 3 and also anemic from the colon cancer. So the surgeons are planning for a right hemicolectomy for the obstructing ascending colon cancer. And they will go to an open approach, and they want to use the monopolar electrocautery above the umbilicus because it will be a big incision. And we are concerned about the risk of electromagnetic interference. So we had a multidisciplinary team meeting. So we assessed the urgency and the risk of surgery. It was a semi-urgent, elevated risk oncological surgery in the abdomen. And the patient has a borderline functional capacity, but he does not have any unstable symptoms. We treated for anemia and sugar and blood pressure. The baseline ECG revealed the paced rhythm, and the echo was adequate. So our plan was to interrogate the pacemaker, and then we would take the decision. So we would interrogate the pacemaker, we optimize the pacemaker function, and then we'll have a formal pacemaker plan. And we did that. So this is the pre-op device checklist. It was a Medtronic MRI shear scan, and we documented the magnet response. The battery has a good longevity, and the thresholds were stable. The patient was totally pacemaker dependent, almost 98 to 100% pacemaker dependency, because there was no intrinsic rhythm at VVI 30. We turned off the rate response system, and we actually programmed the pacemaker to a DOO mode at 80 beats per minute. So there is no sensing at all during the operation. During operation, we monitored the patient through continuous ECG and also pulse waveform monitoring. We actually put transcutaneous spacing pad or defib pad. We had the defib machine close to the patient, and we put the defib pads in the chest away from the pacemaker. And we also asked the surgeon to use bipolar cautery. We asked them to use lowest effective energy for shortest possible time and use not for prolonged period, rather short bursts, and to avoid coagulation heavy activation. And we also asked them to put their electrocautery pad in the thigh so that the electrical axis of the electrocautery does not cross the path of the electrodes or the pacemaker. And we had also a backup plan. If the rhythm disappeared during the surgery due to the electromagnetic interference or some other reason, we would pause the electrocautery, we'd confirm perfusion by checking the pulse and also checking the pulse waveform, pulse oximetry, and the pressure waveform. We would ensure that the DO was active. And if it was actually the patient was having any arrhythmias or asystole, then we would have activation of the rescue pads, and then we restart with the modification. But that didn't happen. So in the post-op, the patient had a very uneventful period. It was good recovery. Everything was stable. And after the operation, we reinterrogated the pacemaker. We restored the baseline DDD mode, and we confirmed all the parameters. And we monitored the patient throughout the post-operative period, and then we discharged in a stable condition. So that is my next case. Okay, so should we move on to the next case, or sir, hold on here?
So you brilliantly explained everything, and one thing is important, that what would you do if the surgery we have to do below umbilicus? What would be our approach in that case?
So if it's below umbilicus, then the risk of EMI is very low. Then we may not do everything. We may not just change any pacemaker setting at all. But obviously that would take a MDT. We will still go for an MDT discussion regarding this. But the general consensus is if the surgery is below the umbilicus, then the risk of EMI is very low.
So this message is very clear that if the surgery is below umbilicus, like hip surgery, knee surgery, cystoscopy, prostate surgery, in that case, actually, we need to do nothing. Is it like that?
Yes.
But
it's always good to have a discussion. But
if the patient is not pacemaker dependent, then what can we do?
If the patient is not pacemaker dependent,
yes,
it's always good to have the idea of how much pacemaker dependency. If there is no pacemaker dependency at all, then we might not have to change the programming. We might let the pacemaker be as it is, because it's not sensing, it's not pacing, it's actually in an inactive state.
So in that case, should we go to the VO mode or DO mode, or we just keep
in that case, changing mode doesn't affect anything because the patient is producing his own rhythm. Then actually we should consider why the pacemaker is implanted, because it's not working. Probably the condition was reversible condition, or Or maybe in that case, we would obviously take an opinion from the EP specialist and do as they say. But from my view, that if the patient is not pacemaker dependent at all, then we might not have to change the pacemaker setting, because the patient does not need the pacemaker, his own rhythm.
Okay, so I will ask Professor Abdul Wahid Choudhury sir for his comment, and we will move to our next case because we are running short of time.
People have, non-cardiologists have unusual fear about dealing with patient with pacemaker. I don't know. I tell the other way around. The patient have pacemaker, so you have a support regarding the rhythm. You don't have to worry about the patient getting bradycardia or getting cardiac arrest out of the way. So you should not be worried about it. The thing is, why the operation is being done. Lower end, it doesn't matter. And high up, yes, you have to plan for it. And as Mr. Bhay was saying, if the patient has mostly dependent on own rhythm, you don't even have to call the pacemaker company to send somebody to put it into asynchronous mode or something like that. You don't have to do that. If the patient is dependent on pacing, then you need to have a backup. And another thing is that, please do not forget that the LV function do not depend upon the pacing. It depends upon the integrity of the coronary circulation. So in a pacing bit where you cannot assess ischemia, please assess the history very well, whether the patient have any active ischemia or not. That's very important. And again, I will emphasize the importance of electrolyte. Please ensure that patient do not have a situation where he or she is prone to develop arrhythmia, particularly ventricular arrhythmia. So avoid hypokalemia, avoid hypomagnesemia, and let the procedure go on very, very peacefully.
Oh, thank you, sir. Dr. Shariful Halim, you can move to your next case. And
Okay, sir. So I'm moving to my next case, case 4. This is a
do you have any
69.
case in heart failure?
Yes, I have a case of heart failure in the last case. Last case is the heart failure case. So
You want to show 4 cases or 5 cases? Dr. Mashrafi, should we go
I have actually 6 cases. So
5th case or 4th case? This would be the last case.
Yeah, let's do this is one last case. Which one, wherever you want. Do you want the valvular heart disease or heart failure? Because it's already like we have 15 more minutes to finish.
I think you can quickly finish this valvular case. You can just show, and then you can move to the heart failure case.
Okay,
we'll discuss the heart failure case.
Okay, sir, sure. So this is a 69-year-old man. He has some heart issues, and he has developed a femur fracture following a fall in the bathroom, and then she needs a surgery for the femur fracture, and the orthopedic team asks for cardiac clearance. This is her recent echo, which showed features of severe aortic stenosis. And we confirmed the severity. It is actually severe aortic stenosis, but she did not have any symptoms. Her ejection fraction was normal. There was no features of coronary artery disease or features of heart failure. So it was an asymptomatic severe aortic stenosis. And the surgery was a time-sensitive or semi-urgent surgery. It has an intermediate risk, and the surgeons do not want to delay the operation. So our MDD decision was to proceed with safeguards. So we allowed the surgeons to proceed with the urgent femur surgery. We did not do any aortic valve replacement. We did not do any stress tests. And we communicated the risk and monitoring plan to the ortho anesthesia. We would have considered the valve surgery first if there was clear aortic stenosis symptoms, or if there was LV dysfunction or features of heart failure. So this was her management. We tried to maintain the preload and avoided tachycardia and hypotension. And the patient had good post-op outcome despite having severe aortic stenosis. So this was our case 4. Now I'm moving to the...
Oh, just 1 second, Shariful Halim. The key message from your this case is that if someone has a symptom is the fundamental most things in assessment of cardiovascular patients. If someone has severe aortic stenosis, but he doesn't have symptom and his LV function is good, he can proceed to surgery, likely intermediate risk surgery. So that's the key information. Okay, you can proceed to the next.
So I'm moving to case 6.
One last question, completely out of context. বাংলাদেশে এখন এটা একটা asymptomatic severe aortic stenosis. What is the culture? Do we still refer for aortic valve replacement?
No,
or-
no, sir. No, sir.
No.
We don't. So now I'm moving to my last case. This is a 65-year-old male diagnosed case of heart failure with reduced ejection fraction. He's taking all the Fantastic Four, including ARNI, beta blocker, MRA, and SGLT. And now he is diagnosed as case of BPH with the prostate volume is so high, and the surgeons wants to do a TARP because he recently developed some episodes of acute bladder obstruction and which required recurrent catheterization. So he needs a TARP right now. Now, should he go for the surgery, and what should be done before surgery, and what should be our decision overall approach to this patient? So I can pause here and we can discuss here.
So I would ask any our resident or the participant can have their comments in the chat box. What would they do? Will they proceed to the surgery or will do further assessment in this case? If any fellows or resident put their comments, or they can talk.
Yeah. আমার মনে হয় মেসেজ না লিখে সরাসরি বললে সবচেয়ে ভালো।
হ্যাঁ হ্যাঁ, সেটা কি এখানে কি বলা যায়, মানে আই মিন ইজ ইট এ ওয়েবিনার fellows can. So if we are running some sort of short of time, so Dr. Shariful Halim, this is a low risk procedure, I think low risk surgery. So
Yes,
is there any
it's a low risk
cardiovascular
surgery.
assessment needed in this case?
Definitely, there should be an MDT because it's a high cardiovascular risk patient because it's a heart failure patient. Even if it's a TARP, the problem with the TARP is there is risk of volume overload in TARP because whenever there is saline irrigation during the procedure, that causes volume overload.
This patient is doing well. He has a NYHA 1 or 2 symptom. He has a good functional
He's actually
capacity.
functional capacity is NYHA right now too, and he's doing well. But there
He's doing well. So do you need any further assessment?
That's a very good question. So I'm showing what we did. So this patient needed an electric NCS, and this is the guidelines. So this patient, although this is a low risk surgery, but still any heart failure patient requiring a surgery has a higher risk of mortality, which is if the EF is around 30 to 39%, there is a 2 times higher risk of mortality. So we actually assessed the NYHA class for this patient, assessed the volume status. The patient was doing well. We reviewed the echo. The EF was around 35. LVRD was around 56 something. And we assessed the NT-proBNP to see if the patient is in control of the heart failure, which he was. We calculated the RCRI risk and NSQIP risk, even if it was a low risk surgery, but the spatial nature of the surgery that the patient might develop volume overload during the surgery actually told us to do everything. And we actually went for the surgery because everything we did said us that the patient can safely go to the surgery. We did one thing, we stopped the SGLT about 3 days before, but we continued the other heart failure medications, including the ARNI. And interoperably, we specifically told the surgeon to use as little volume as they can because the TARP has a high volume overload. We avoided hypotension and we used invasive monitoring. And we asked the anesthesiologist to decrease to use those drugs such as etomidate, Fanta, vecuronium, or sevoflurane to the lowest possible amount that they can because those can suppress the myocardium during the operation. So this is our post-op.
Or just a quick thing about for the students who, if they, I don't know anyone here, but do you guys know why we ask SGLT2 inhibitor to be stopped 3 to 5 days before surgery? Why anesthesia will particularly recommend to stop the SGLT2 inhibitors few days before surgery?
So should I answer it, sir, or wait for the student, sir?
You can tell. Yeah,
okay, sir. Okay, sir. So during surgery, there is a high risk of euglycemic ketoacidosis from the SGLT because pre-surgery, the patient is often not taking any food. The patient is in NPO status. There is high catabolic state, And there is high risk of development of this euglycemic ketoacidosis, for which actually we should stop this drug, SGLT, at least 3 days before, so that the drug can flush away and does not cause this ketoacidosis during the surgery or post-surgical period.
Yeah,
Dr.
so
Mashrafi,
that's
one
the
thing,
anesthesia. Sorry.
sir. Dr. Mashrafi, one thing I want to know from you, that doing NT-proBNP in this patient, I mean, if this patient is symptomatically stable, could we go for the TARP directly without this NT-proBNP and
Yes. I usually do not do proBNP if patient is compensated. If patient is decompensated, then we try to do proBNP and try to, TARP is not an emergency surgery, right? So any pre-surgical cardiac risk assessment, the first thing is, what is the surgery happening? Is it a life-saving surgery and semi-emergent surgery, or it's like a regular surgery or not? Because if it's a life-saving surgery, there's no meaning of really delaying by any sort of cardiac risk assessment preoperatively, because we have to save the patient's life. But here, TURP, it's not an emergent surgery. So the goal here is to make sure that the patient is, with a history of heart failure, is decompensated or not. And if patient is decompensated, we have to give every effort to make them compensated, stabilize them, and you can do a proBNP and assess what the risk could be after the surgery. So if the proBNP is very elevated, then there are risks are higher. So you have to be more cautious in the perioperative period for all the fluid management and electrolytes and everything. So how much, there is no, in fact, strict data like, okay, what would be the parameter to say this much of proBNP will help or judge you to do particularly this thing or the other way. There is nothing like that. It's just like a risk assessment thing. And I only do it if there is decompensated state, not in the compensated state.
So Dr. Shariful Halim, one key message from 2024 guideline is that sir, we should do less test. I mean, we should judiciously use echo, we should judiciously use LV function, we should judiciously use proBNP, we should judiciously revascularize before surgery. Many of the times these are overused. We do, suppose someone has a cataract surgery and he go for ECG and echo. And actually someone with dental extraction, he asks for antiplatelet to be stopped. Some minor ECG change. But the fundamental thing is that if the patient doesn't have a symptom like chest pain or severe chest pain or severe shortness of breath, have good functional capacity, you can proceed to many of the surgery. That a low risk surgery you can proceed, and in case of intermediate to high risk surgery you also can proceed. So the key thing is that patient's symptoms, patient's functional status, patient's how the patient is doing. So we are nearly end to this program. I would ask our respected panelist, Professor Abdul Wadud Choudhury sir, to give some advice and comment, and we will finish.
Shariful Halim has done a beautiful job presenting different types of patients: acute coronary syndrome, chronic coronary syndrome, patient with pacemaker, elderly patient, youngish patient. And that's the mix of patient that we get in real life. So the different types of problem that we face, if the youngsters today see this program, either now or recorded, that will be very helpful for them. Shariful Halim, thank you for that. And the learned panelists and experts, the opinion they have given, that's very important. And the last comment that was made by Alamin regarding that we are overdoing things and we do not study. The guidelines are there. The seniors are there. Why don't you go through the guidelines and talk with the seniors, because you have to think about taking into context the situation that you are doing the job. What we have in Bangladesh and what we have in USA are not the same. So you have to use your common sense as well and prioritize what you need to do. Do you need to do it now? And if you need to do it now, can you put it in an algorithm way? If you can think like that I need to do this to this to this to this, then that will be very helpful for the safety of the patient. And always, please always think about the safety of the patient. The outcome of the whole procedure is the most important thing. It's not that you're going to only save cost effective or something like that, because the life is much more important than 80,000 taka. That's also very important. Sometimes we cut the cost, we cut the corners to make sure the patient can undergo the surgery in my clinic or in my clinical situation. We should not be doing that. We should be thinking about what can happen to the patient and have a plan ready. If the patient develops this problem, what am I going to do? A patient having LVH and diastolic dysfunction is very likely to develop atrial fibrillation. If you have, if you put the patient through stress because of over infusion, so you can tell the anesthetist the patient may have atrial fibrillation, and please keep sure that you have a meter with you. That's a simple thing, but that will help the anesthetist to plan for it, and they can avert many a time many complicated situations. So paying attention to detail is what is important, and getting up to date with the guidelines and with the comments from learned experts like that. I'm sure if you call Mashrafi in USA, if he gets the time, he will answer you. He can guide you. If you call any one of us, I don't think any one of us will refuse to guide you to help you to go through the whole thing. So, Shariful Halim, well done.
Thank you, sir. Thank you so much, sir.
Thank you.
It means a lot.
Dr. Mashrafi, now you can give concluding remarks and finish our session.
Shariful Halim, তুমি সবসময় খুব সুন্দর প্রেজেন্ট করো। That's, I know you are really a brilliant one.
Thank you, sir.
সোশ্যাল অ্যাসপেক্ট অফ মেডিসিন হচ্ছে একটা বড় জিনিস আর কি। আমাদের এখানে আমরা যেটা প্র্যাকটিস করি সেটা হচ্ছে যে যখনই একটা রোগী আমাদের কাছে আসছে যে আমি একটা সার্জারিতে যাব, আমাকে পাঠিয়েছে তোমার কাছে যে আমার সার্জারির রিস্ক কি বা আমার হার্টের বা কার্ডিয়াক রিস্ক কি সার্জারির জন্য, তো প্রথম যে কথাটা আমি সাধারণত বলে থাকি যে there is always risk. There is no absolute zero risk, right? So whether the surgery is high risk surgery, moderate risk surgery, or low risk surgery, or patient's cardiac risk is high, moderate, low, whatever, however we try to designate this thing, it has to be very clear there is always a risk. A young person may go for a very low risk surgery and still can have complications, right? So this is the beauty of counseling. Now it's tough to do counseling many a times because we have a huge patient load, particularly in Bangladesh perspective, and that sometimes creates a lot of unwanted situation. But the straightforward message would be any surgery will have any risk, but it's a low risk. It's not zero risk. That's what at least I try to tell the patients to make it clear. Thank you. Good job.
Thank you, sir.
Thank you, our respected panelist, Professor Fazl Nasser, sir, Professor Abdul Wadud Choudhury, sir, Dr. Sharmin Abbasi, Dr. Shafiqul Islam, sir, and Professor Choudhury Hafiz. He could not be with us, probably for being busy. And thank you, our audiences, and thank you, our industry partner. Hope to see you next with our next session. Thank you very much, Dr. Shariful Halim, for your brilliant presentation, as you always do. Thank you very much.
Thank you, sir.
Assalamu alaikum.
Assalamu alaikum, sir.
Assalamu alaikum. কেসগুলো খুব ভালো ছিল রে।
Thank you, sir. অনেক কিছু শিখতে পারছি স্যার আমি কেসগুলো প্রেজেন্ট করে স্যার।
বুঝছো, আমার কাছে সবচেয়ে লাগে কি জানো, ওই যে যখন কার্ডিওলজিস্টের কাছে পাঠায়, তখন সবাই খালি বলে যে এটা মডারেট রিস্ক, এটা রিস্ক। ভাই আমি এটা রিস্কের জন্য তো তোমার কাছে পাঠাইছি। তুমি তাকে বলবা তুমি এইভাবে এইভাবে করো, এই প্রবলেম হতে পারে, এটা করলে তোমার প্রবলেম গুলা কম হবে। মাস্টাফি যেটা বলছিল এটা একটু দয়া করে বলো। আমি তো রুগীতে বলি যে ভাই ওনার রিস্কটা কমানো হলো আমার কাজ, ওনার রিস্কটা টোটালি এলিমিনেট করার ক্ষমতা আল্লাহ তাআলা আমাকে দেন নাই।
রাইট, রাইট। এটা মানুষ অনেক সময় ভুল বোঝে যে যে ডাক্তারের কার্ডিওলজির কাছে এসেছি আমার রিস্ক উইল বি লাইক এলিমিনেটেড, রিস্ক সম্পূর্ণ চলে যাবে। না,
এলিমিনেট
রিস্ক
করে না,
আসলে
কিন্তু আমি রিস্ক
কখনোই
রিডিউস
সম্ভব
করতে
না।
পারি।
আমরা
এবং
রিস্ক রিডাকশন করার চেষ্টা করি, কিন্তু রিস্ক সবসময় থাকবে।
এবং এটা কি কি হতে পারে সেটা কিন্তু আমি এটা প্রিলিমে দিয়েছি। ওরা কিন্তু এই জিনিস প্রবলেম করলে চান্স হয়তো 1%, কিন্তু 1% হলে ওই রোগীর জন্য তো 100%।
রাইট।
আর হলো এটা অ্যান্টিসিপেট করা, এই প্রবলেম হতে পারে। আমার একটা অভিজ্ঞতা হলো আমাদের দেশে পেরি অপারেটিভ নন এসটিএমআই অ্যান্ড এলভিআর, দ্যাটস দ্য সিরিয়াস প্রবলেম। তার একটা বড় কারণ হলো পার অপারেটিভ হাইপোটেনশন হয়, তখনই রুগীর কিন্তু একটা নন এসটিএমআই হয়। তারপরে যখন ফ্লুইড দেয় তখন যায় রুগীর তোমার লাং একদম ফ্ল্যাট হয়ে যায়। বুঝছো, এটা একটা সিরিয়াস প্রবলেম। আমি এদের বলি যে যখন এরকম পেশেন্ট আমি যে ভাই তুমি দরকার পড়লে একটু নরের বা কোনো একটা ইনফিউশন দিয়ে একটু প্রেশারটা একটু উঠায় রাখ, একটু বেশি করে রাখলে তার কোনো ক্ষতি হবে না। কিন্তু যদি কমে যায় তার কিন্তু নন এসটিএমআই হবে, এবং হলে পরে তখন দেখবা তুমি হাইপোটেনশন, তুমি আবার দিয়ে ফ্লুইড তাতে যাবে পার্মানেন্ট। আর অ্যাট্রিয়াল ফিব্রিলেশনের চান্সটা এই যে পেশেন্টটা থাকে এইটা যে কত ইম্পর্টেন্ট। এফ হলে পরে একটা পেশেন্ট, বিশেষ করে যার এলভি ডিসফাংশন আছে, তার তুমি 25% 30% ইফেক্টিভ কার্ডিয়াক আউটপুট কমায় দিচ্ছ। এটা বুঝতে হবে, কিন্তু খুব ইম্পর্টেন্ট জিনিস। আর হাইপোক্সিয়া যাতে না হয়, হাইপোক্সিয়াটা অ্যাভয়েড করাটা খুব জরুরি। আরেকটা জিনিস যেটা খেয়াল করা দরকার, কিপিং হিমোগ্লোবিন অ্যাবাভ এ সার্টিন লেভেল। তুমি 10.5 এর উপরে রাখো, দেখবা যে তোমার অনেক রিস্ক কমে গেছে। আমি খুব জোর দিই ভাই হিমোগ্লোবিনটা ভালো রাখো, ইলেকট্রোলাইটটা ঠিক রাখো, আর ফ্লুইডটা একটু হিসাব করে ইউজ করো, ব্যাস শেষ। দেখবা যে তোমার অনেক প্রবলেম সলভ হয়ে গেছে। খুব খারাপ খারাপ পেশেন্টেরও এইভাবে অপারেশন করে আনা যায়। খুদা হাফেজ।
থ্যাংক ইউ স্যার। থ্যাংক ইউ,
Thank
Sharif.
খুদা হাফেজ।
Thank you, sir.
Love it.
Alamin, thank you.